Good morning, one and all. Welcome to this webinar. To begin, our bandwidth will be very limited, so you are kindly asked to place in the chat, as some have started doing, your name, country, structure, experience with PBC, and in order to strengthen the interactions between clients and providers. Slide, please. So again, allow me to bid you welcome to this webinar called Sharing Results of the Process to Strengthen Interactions Between Client and Provider. This is the first of a series of 3 webinars entitled Focusing on Compassion in order to get better result in reproductive health and family planning. This series of webinars is offered to you by the West Africa Breakthrough Action, which we call WABA. My name is Hilaire Tokplo. I am a health communicator, regional advisor for behavior and social change on the WABA. Slide, please. The speakers will speak in French, so please kindly select the language channel of your choice as indicated on the slide. The WABA project, West Africa Breakthrough Action, run from July 2018 to December 2023. It is funded by the Health Regional Office of USAID in West Africa. Its general goal is to increase access to modern family planning, and it's informed and voluntary use in Burkina Faso, Cote d'Ivoire, Niger, and Togo. The specific goal of the work that we are presenting today is to improve the client service provider interaction in order to increase the quality of family planning services. For our agenda today, we are going to present to you the process related to the development of tools in order to improve the behavior of health providers in the 4 countries with diagnosis studies that were carried out all the way to the proposed solutions for each country and the scaling up of these solutions. Then we will focus on the Yasoma tool, which is from Burkina Faso. Then we will share experiences and testimonials on the implementation and scaling up of these tools in Cote d'Ivoire, Togo, and Niger. After that, we will share the links to all the tools that were developed in the 4 countries. Then we will have the question and answer session. Later on, we will have a short survey to get your opinion, advice, and evaluations on the seminar before closing our session. Before starting, I would like to mention that all microphones will be cut off except for the person speaking. If you have any questions, kindly write them in the chat box. The webinar of today will be recorded and it will be published on the Breakthrough Action website so that those who wish to access it can do so freely. Here are the speakers for our webinar. First of all, we have the pleasure to invite 5 of our colleagues from the WABA project who will present our common experience in all 4 countries. The process has also benefited from the technical support of almost all the partners of the Breakthrough Action Consortium, meaning Camber Collective, CCP, IDS 42, Save the Children, and ThinkPlace. We are welcoming all these partners and colleagues today. They will join us for the entire process. We have many partners. I would like to just mention Dr. Agosu from Togo's Ministry of Health, Dr. Ano for the Momentum project on Côte d'Ivoire, and they will both mention the process and how it developed. How can we improve service provision in the field of family planning? Can we still talk about um, change in the behavior of the providers, PBC? Why this change? We don't want that the entire burden of the quality of service be placed on the shoulders of service provider. We understand that they have to operate in a context that includes the health services, but also the community. So in this map of the ecosystem of service provider, we have an articulation of the ecosystem that includes 8 factors. These factors that you see around the circles on the slide are the individual, personal relations, client, community context, social standards and norms, work environment, health system and governance, and the geopolitical context for the country. Our process for the development of our interventions appears here on the slide. This is what we call the SBC flowchart, or social behavior change flowchart. The 3 phases of the process bear stressing. The first one is a definition of the issue as well as the intent of our work. Phase 2, design and test solution prototypes vis-a-vis identified problems. And third phase, the final one, is the implementation of solutions in real life situation. So we're going to start with the first phase of the process, meaning definition of problems in the 4 countries. It is my pleasure to introduce our colleague Alice Molinier, who is engagement manager with Camber Collective. Alice has 12 years of experience in the field of sexual and reproductive health and has been working for 3 years on the WABA project in the 4 countries. She carried out the basic studies in the 4 countries in order to launch the process. You have the floor, Alice. Thank you very much, Hilaire, and hello all. Let me introduce quickly the study that was carried out in 2020 in 4 countries for WABA. The goal of the study was to gain a better understanding of the environment for health providers and identify the main challenges to which with which they were faced. We wanted to have an exhaustive vision and a clear understanding of the various points of view. Therefore, we interviewed in all 4 countries health service providers, member of government, as well as implementation partners. The interview dealt with 3 elements. First, what are the challenges to which providers are confronted? Second, training and supervision. And third, we mapped the tools that were already used in the country. This slide on screen presents a summary of the main challenges that were identified in the countries, and in order to introduce them, we have used a tool called Health Provider Ecosystem, which was developed by Ye and which organizes the challenges in 7 categories. On the top right, you have the individuals with his or her personal relations. At the bottom, the community, social norms, and the client. And on the left, all the dimensions that are more cultural or professional for the provider. This slide is a summary. I'm not going to go into it in details, but it summarizes the challenges in the 4 countries. Each country has its own challenges that may have different level of priorities. And for us, what was important was to identify one priority challenge in each country in order to design the specific intervention. Thank you. So In each country, we presented the challenges, and then we asked our partners, the government and the providers, to identify one challenge on which they wanted to work. Those challenges are presented here. In Burkina Faso, the partners decided to work on the issue of motivation of service providers. In Côte d'Ivoire, we worked on the lack of a standardized and exhaustive advice and counseling tool. In Niger, like in Burkina Faso, we worked on the lack of motivation of providers as well as the existence of a simplified tool. And in Togo, we worked on structural elements and we focused on the issue of the inadequate flow of clients between the various services in health facilities. So these are the challenges on which we decided to focus our efforts, and this will form the basis of what we have done today. And I am giving the floor back to Hilaire. Thank you, Alice, for describing to us those challenges that were identified with all of our partners in the 4 countries. We are now going to look at the second phase of the process, dealing with design and testing of solution prototypes, as happened in the 4 countries. I am now going to give the floor to Mrs. Finu Mendy, who's also a member of the WABA team and represents Ideas 42. She was involved in the process in its entirety in the 4 countries. As a reminder, she works in applied behavioral sciences on health for the past 7 years. She is a behavior designer, senior behavior designer for Idea 42. Finu, you have the floor to introduce for us the elements of phase 2. Thank you, Hilaire, and greetings to one and all. This diagram that you see on screen is a small reminder of the process at the design and testing phase that was presented earlier on the process of social and behavioral change. What one needs to understand is that for design, we didn't start from scratch. We first started with the identification of existing solutions that could potentially meet some of the prioritized challenges in each country. Thus, each country, during the exchange of ideas, has refined some of the groups of solutions to be selected, always in connection with the challenges. Then we've established an order of priority for a group of solutions according to a number of criteria: relevance, feasibility in time, resource, country context, as well as the existence of similar intervention in order to avoid effort duplication. Following these exchanges of ideas, we did an adaptation of the solution in order to see how we could improve the tools in order to meet the challenges in service provision, to see what an improved tool could look like, and also to see if the selected tools needed to be combined or tested separately. Next, during the prototype phase, we have created preliminary version and seen how these solutions could be incorporated into the existing tools in the various countries. That's an important element. The prototypes were modified a number of times with the feedback from the stakeholders during the various testing process. For instance, in Burkina Faso and Togo, we had 2 rounds of tests with users, which allowed to refine the prototypes before the pilot phase. Following the pilot phase, the teams also improved the prototypes on the basis of the pilot phase's results before scaling them up. These activities have allowed to strengthen the capacity of the country teams and partners in terms of user-centered design.
The design process, which focused on adapting existing tools, was similar in all 4 countries. we carried out more or less the same activities. This was done with the participation of various stakeholders in each country. This was done with the clients themselves and the providers, as well as actors at the ministries of health at the central level and in the health regions and districts. We also worked with other implementing partners. After that, combinations, we created combinations with the prototypes to be tested in order to ensure that all priority challenges were met. To your left and up top, you have images of the prototypes from Niger that were developed during these workshops. We have the segmentation tool at the top and the customer provider promise tool at the bottom. Both prototypes were hand drawn by the participants. They were modified several times during the workshops. And we got feedback from the users during testing, as you can see here on the right. These adaptation, prototyping, and testing sessions also enabled us to verify the challenges that had been identified at several levels. We were also able to identify the mechanisms to overcome these challenges. In a similar fashion, during testing, some prototypes that had been created during this phase were taken out of solution packages at the end of the test. So the prototype combinations were tested in various country contexts in order to ensure the adaptability while making sure that we were able to maintain the potential impact of each solution. Throughout the process, project teams, partners at the central level, and partners in the districts and regions shared knowledge and practical experience with designers to help with the development of pilots and improvements for scaling up these solutions. And I'm very happy to introduce my colleague Abubakar Sawadogo, who is the Regional Community Health Advisor for the WABA project with Save the Children International. Buba is going to talk to you about a prototype testing in Burkina Faso. Over to you. Thank you, Finu. I'm going to talk about prototype tests and pilots that were performed for 2 months at 10 sites in Burkina Faso. We had 7 prototypes to test before, during, and after a family planning consultation, according to typical success indicators used in HCD human-centered design programs. We performed 2 rounds of testing in 10 health centers with clients, providers, supervisors, and the managers of healthcare centers. The test consisted of interviews, observations, routine data collection, all of this with 56 people. The prototypes were then adapted on the basis of user feedback in order to develop the final version of the tool, which is known as Yosoma, which in the local language, it means something that is approved or something that is of high quality. So the pilot took place in 10 centers for 2 months. We had one supervision per month and data collection. We also helped to build the capacity of the country teams and partners in human-centered design. This was necessary in order to enable them to better conduct tests with regard to these indicators. So these are the indicators here on this slide. We looked at viability, desirability, and um, feasibility. Next slide. Next slide. So what are the tools that we had in Burkina? We have Yasoma, which is comprised of 3 kits. There is a launch kit, there is an empathy kit, and there is a satisfaction kit. There we go. Can you hear me? I think there's a bit of an echo on my end. Can you hear me? Yes, we hear you very well. Thank you. Okay, when we're looking at motivation, the WAPA team in Burkina Faso took a a holistic approach based on 3 pillars: empathy, communication, and satisfaction assessment. The team created 7 solutions that were led by a single question that inspires innovation. The question is, how can we better motivate providers to communicate with each other and with their clients so that they can provide high quality family planning, counseling, and services? So that is the question at the heart that led us throughout the process in development of this prototype. Next slide. As I was saying, there are 3 kits that we developed. The first is the launch kit. It contains all the information and advice to get Yasoma up and running in a center. So you start with this launch kit in order to get it set up. So we have a promotional sheet, which is designed in order to create interest in Yasoma in a health center. It provides a brief overview of the tools on the front, and it explains how a health center can adopt it on the back. The second tool in the kit is an initial orientation session, which targets all FP providers at the health center. It provides information needed to implement and use the Asoma tools on a daily basis. The third tool is the support and follow-up guide. This guide provides information on the implementation process and the daily use of the Asoma tools. It is managed by the focal point within the healthcare center, and this person is responsible to explain the proper use of the tools throughout the process. Next slide. The 2 other kits, the empathy kit and the satisfaction kit, each contains 3 tools. The empathy kit is comprised of card games. So there's a card game that is meant to improve the learning and practice of empathy. It is for providers to play with each other. This kit also contains something that we call continuing education. It is a calendar, as you can see here. So it is a calendar that should be hung up in the restroom for providers, and it contains 12 themes to deepen knowledge and empathy skills. The third tool is a checklist. It is a series of reminders with regards to counseling and other interventions to ensure a good relationship with customers during consultation. And then the third and last kit is what we call the satisfaction kit. The satisfaction kit contains 4 tools. There is one for customer feedback coupons. So this allows clients to give feedback on communication and empathy after a consultation. Another element, posters that can be put up in the waiting rooms in order to give a place to put in the customer feedback coupons, as well as video and audio instructions on how to fill out the form. Next, we have the self-assessment booklet. This enables each agent to measure his or her own progress in empathy and communication. This is on a monthly basis. And finally, the fourth tool is the monthly review and rewards booklet. This is an evaluation process that covers client feedback, provider self-assessment, and the assessment of a supervisor in order to award recognition badges to the best providers. At the end of each month, we will carry out this process. So those are the kits. And so now I'd like to hand over to my colleague Hilaire, who will talk about phase 3, which was applying the tested tools in real life situations. Hilaire, please go ahead. Thank you very much, Abuba. Now, as you said, we will move on to the third phase of our process. That of applying the tools we've created to, we've applied to real life situations in the countries. It is worth mentioning that the use of these tools depends very much on our partnerships. We have built up relationships with various ministries of health and with different branches of the ministries, particularly with healthcare providers, the directors of healthcare facilities, district medical officers, heads of departments, and in particular, those who are in charge of reproductive health and family planning departments. We'd also like to mention the involvement of implementation partners of the WABA project. For example, Amplify PF, the Momentum Project, Kulawa, and affiliates of IPPF, such as ABPF, ABBEF, and others. These are all partners who have worked on the implementation of this process in our countries. Next slide, please. So now we will quickly talk about Togo's tool, which we call the SOC. In Togo's case, you remember the main challenge was client flow in order to reduce their frustration in knowing where to go or where they are in the system. So these are the concerns that led us to create this client orientation system. It is a color-coded client orientation system, or we call it the SOC. It is a very simple idea, but it is effective to improve the flow of customers into departments, to reinforce referrals, service appreciation, it creates order, etc. This SOC system is simple. Mainly, it comprises of the signs that you see with arrows that you can put up on the walls, signs on the doors, and provider badges. These various elements of the SOC were tested with users and with staff in 10 health centers. It was then piloted at 15 sites for 2 months. And right now, we have come to the phase of scaling up this project at the national level. We have also worked with a manager at Togo to talk about its usefulness. Next slide.
So we are delighted to now move to the panels of experiences within the country for the implementation of the various tools that you have just looked at. In order to do so, we have invited some very important people who will share with us the information about implementation of the tools in those countries. Slides, please. Very first person I would like to invite to speak is Dr. Agosu Abram, who is the director of mother and health and child health at the Health Ministry of Togo. He received his MD at the health Science School of the Lome University. He has a DS in pediatrics from the same School of Medicine and a master's in public health from the Institute of Tropical Medicines from Antwerp. He has already been a doctor, head of pediatrics, head of district doctor, and in charge of maternal health and family planning before taking the position he has today. Thank you. As you have seen, there are 3 levels in the intervention process. The colors and the walls, and then you have the name of the providers. The system was particularly useful for the client because it allows the client to easily find the service that they are looking for. The system is also guaranteeing privacy because a client doesn't have to go and ask anybody. They can go directly into the service of interest. So there's no time wasted, no waiting at the window for the information. They can just know right away where they're going. For the provider, it is also increasing their peace of mind because they're not interrupted during their activity by somebody who's looking for information, opens the door, asks a question, looking for a different department. So this is really simplifying the process. This also improves the interactions with providers because people are not disturbed by questions, annoyed by the details. The provider is able to make sure that their advice is followed. As far as training is concerned, the flow of patients, circulation is done well, visibility is improved on services provided. People can just walk in, see where they're going, will get the service they need. So this, in a nutshell, is how this particular system is providing and how it is helpful for both the provider, the client, and the health service as a whole. Thank you, Dr. Agoso, for this contribution. In Togo, we are at the scaling up stage. So could you tell us a little bit about the deployment, the efforts deployed by the Ministry of Health for the scaling up? We have been able to focus on health functions in Togo with a microplan where the provider can determine how they contribute for the year to come. So the calendar is established, it is done well, it is appreciated, and this will be part of all the activities that will allow for the implementation of the health services. As far as financing, there are 3 levels. Income providing from service provided. And then there is, of course, the support of the state and providers' support. So everybody is convinced of the usefulness of this approach to implement everything that needs to be implemented. Thank you very much, Dr. Adugosu, for telling us what happened in Togo. In Cote d'Ivoire, we have the Momentum project, which has substantially contributed to the implementation of the tools that was developed. Do we have somebody from Momentum? Is Dr. Arnaud with us? If you are Dr. Arnaud, can you tell us what the contribution of the Momentum project in Cote d'Ivoire, please? Thank you, Hilaire. Greetings, one and all. Indeed, in Cote d'Ivoire, GH Payago through the Momentum project, which is funded by USAID, was part of the process which allowed the drafting of the counseling guide for family planning in Côte d'Ivoire. We needed a guide, and we needed a coherent, consistent, single guide to ensure service provided that would be of quality. So with our partners of WABA, the ministries, and the PSE, we have drafted this guide to contribute to the offer of family planning services of quality. As far as the scaling up process, we've have started the interventions in 450 sites in 48 districts of the country. And following that, there will be a discussion followed by an orientation for the various providers to make sure that there is an effective use of the tool. This is an important tool for family planning in Côte d'Ivoire. So this is what we have been doing in Côte d'Ivoire. I thank you. Thank you, Dr. Arnaud. Thank you to all these partners who are helped with the dissemination of this information and contributed to the improvement of services. I would like to introduce my colleague, Dr. Umaru, who is a doctor in science and has a master in education. He's been working for over 15 years in the development arena. He works with the WABA project as technical advisor in reproductive health and family planning. Umar, could you tell us a little bit more about the segmentation tool that was developed? Thank you, my friend Hilaire. Greetings to all the participants. The segmentation card that we've developed, customized as our friend Hilaire, following the challenges that we had to meet in Niger, including a lack of motivation, the lack of specificity of counseling. So the segmentation tool had been created by Canber in Niger in 2014 as a tool that could help the specificity of counseling services as well as reduce its duration. This tool, although it exists since 2014, did want for use because those methods that would make it easier to use were lacking themselves. So we remember a provider in family planning who told us that they do almost no counseling. We are only authorized distributors of family planning products. This may explain the frustrations of the active distribution of family planning services in Niger. So the tool was tested, a process was put in place to improve it. As you can see, this has allowed us to create this card with about 50 columns with a category of people and their characteristics. And this is how we got to where we are today. By using this tool, by determining the segments to which the client belongs, we are able to focus our counseling services and be more specific in our intervention, thus not providing information that seems useless for the client and that would reduce the counseling time. this card combined with the segmentation and method card. The segmentation card is the one for each segment, where among the 5 segments, we've developed arguments as to what needs to be said to the clients in that segment. And the method card is what should be said according to the method selected by the client, the information that the client may need. All of this allowed to make counseling more specific according to the needs. Thank you very much, Dr. Umar. We know that these tools today are integrated in the tools of the Ministry of Health in Niger. How did you do this? Yes, indeed, these tools for counseling have now been incorporated, particularly for the KF card, and we included it. The segmentation card was included in the FP card through the long process that I explained, all the way to the validation. And once the national validation was obtained, the ministry decided to integrate it in the national family planning card. They also decided that it would be good to translate all these little boxes that you see in the 3 languages most spoken in Niger in order to facilitate its use. Integration and translation combined have helped the EDPF and the partners to finalize the training of all family planning providers in the Chilabili region, and they are starting on the other region in order to move with the scaling up process. Thank you. Thank you, Dr. Umar. Thank you to the Ministry of Health of Niger and all the actors of this contribution. We've been talking about tools, countries, process. I'm sure that you do want to have access to the tools. So it is now my pleasure to introduce Juliana Rojas, who is a consultant in graphic design for the Think Place team. She worked with us throughout the process. Juliana, would you kindly and quickly introduced us the resources on all the tools that were created? Yes, thank you, Hilaire. I have listened to the presentation, and now we're going to share with you a number of very important resources where you can find more information on the tools and how you can use them. The first one is the technical card on best practices, where we've gathered all the main lessons from the process. Then we have the card for providers behavior ecosystem. This is an interactive graphic illustrating the various actors, entities, and elements that have an impact on the provider's behavior working within a health facility, and as well as the manner in which these factors interact one with the other. It is accompanied by the third and fourth resources, a summary of the provider's behaviors ecosystem card, and the one for the provider's behavior ecosystem work. Yep, next slide, please. Finally, if you want to have more details on the process, I encourage you to go to this website where you will find an interactive itinerary as for the processes in the 4 countries. I thank you. Thank you, Juliana, for these resources. We're going to put them in the chat so that everybody can look at them. We're now going to move to the question and answer session on everything you have heard since we started the webinar. So please write your questions in the chat and our colleagues will be able to answer, and we will invite some other people with experience in the field to also answer or ask question. We have about 10 to 15 minutes for the question and answer. Let's start. Please put your questions in the chat. Thank you.
While waiting for you to put your questions into the chat, here are some questions that can help us to get a better idea about your concerns and about your questions. If these questions resemble your own, then we are ready to respond. If you have other concerns, other questions, then please go ahead and add them in the chat. And once you have added your questions to the chat, we will take the time to answer as many as we can. So I see that there are quite a few questions in the chat. If you'd like, I can read them out. I see that there are quite a few questions that have been added to the chat. Colleagues who are here online, there may be some questions that are specific to you that you can answer. So I would ask you to go ahead and turn on your mics and answer the questions for our speakers. Yes, Abuba, if you would like to go ahead and answer some of these questions. Yes, a question has been asked about the sustainability of these tools. In Burkina, we have partners with whom we have discussed questions regarding the tools. For example, we have worked with private healthcare establishments that are working on this question. We wanted to pass the lead to one of our partners, IPPF, so that they could work to make sure that these tools are used in the long term by our different health partners. And this was something that allowed us to make sure that these tools would continue to be used. So we worked with our local partners, and they were essential to this process in Burkina Faso. Thank you very much, Abuba. I also see that there are questions about the card decks, the card games. Yes, I will take that one as well. So we have several different versions of these card games. We have a paper version and we have a digital version. We are currently developing the digital one. I think it should be available pretty soon. It is a card game that is used among providers, and it can also be something done by providers and supervisor. We are working at the community level to develop similar card decks that can be used by clients working with providers or young people and adults or members of the different family. We want to make sure that there's a version for the community members. We also have a version that can be used for health workers that can be played by health workers and their supervisors and providers. So that is what I have to say about the use of these card games. Providers have come up with different ideas. For example, they use their WhatsApp group. They'll use the WhatsApp group to play cards. And once we have the digital version, they will be able to do that much easier. Everything can be done online, even when they are quite far apart. So they continue to play these games using WhatsApp. So if there are other colleagues like Erin or Claudia who would like to give us a few more details, well, considering that we don't have a lot of time left, but we do have many questions, let's move on to the next question. I'd like to remind you all, though, that you can see these games. You can see how to play these card games. All of these tools are available. We have put this information into the chat, the different links. I see a question about partnerships. Yes, with regard to the partnerships, one thing that is very important is we have a mechanism with regards to the quality. We have a group of directors that work on this, and they work with the different partners in order to look at the results and see how can we get support for the assessment and evaluation of these tools. We also know that we have very good mechanisms to work on this. I think that this is something that we can continue to work on and scale up. Dr. Agusu, perhaps you could continue to talk about information sharing, experience sharing with the SOC, and also at the regional level. Yes, thank you very much. Recently, the CPO wanted to know how to encourage studies in the 9 countries around Togo. And this study enabled us to improve providers' behavior. And the 9 partners were there, the different actors and stakeholders were there, and we were able to talk about how to improve communication, how to improve other aspects of service provision. It's also a way to look at what is going on outside of the country. Internally, we do have meetings, and the partners can talk about what they have done with regards to healthcare and health services in the country. And with these discussions, we can talk about what we can do to scale up the SOC. Thank you very much, Dr. Agosuf. Here's another question. A question with regards to the challenges related to the implementation of these tools. What kind of challenges have come up when using these tools? For example, we had the co-creation workshop and many different workshops. So we are curious about, we know that there have been different challenges for the different users, the different clients, the different providers in all of our different countries. We have also seen some limitations, some restrictions, some blockages. And when we're looking at health information beyond that, we know that there's a need to explain services, to explain what services clients need. As my colleagues explained, the segmentation tool has been translated into several different languages in Niger. We know too that issues of comprehension or understanding or language or insecurity can all contribute to the challenges related to the use and also to the scaling up of use of these tools. I don't know if there are any other questions. Yes, Hilaire, I had a question about segmentation. Yes, of course. So please go ahead, Umar. Thank you very much. So one of the participants has asked, how can providers identify the segment that a client belongs to? And the info sheet that we created, we have columns that correspond to the different segments. And there are 5 different segments, and there are 12 questions that can be asked in order to identify the segment to which a client belongs. For example, question, have you come in before for family planning services? And so with each question, there is a number of points that is awarded according to the response. So once you have asked all of these 12 questions, you will have a points total, and then you will be able to add up all the different points from all the questions and determine which segment the client goes into. With the points, you can identify which column the client belongs to, and that will let you know which segment the client belongs to. If 2 columns are equal, then you should use the column that is more to the right. And that is the identification process that is carried out by the provider. Thank you very much. We are getting to the end of our webinar. But before we conclude, I would like to ask you to please take a few minutes to respond to our survey. So if you could just very quickly take a few moments, we're going to put the link into the chat. This will help us prepare for our upcoming projects. Thanks very much for your very active participation. We are so pleased to have you with us, and we look forward to seeing you at the next webinar. Thank you very much, and we'll see you soon. Thank you. And you can continue to respond to the questions of the poll, even if the webinar has ended. Please feel free to go ahead and respond to the questions. Thank you very much. We'll see you next time.